Nursing 152, Focused Interview Project. Background. The patient is a 78-year-old Caucasian married male. He is a retired systems analyst for Ford Motor Company, as well as a 3-year veteran of the United States Marine Corps, now retired. He usually receives his medical care from Oakwood Annapolis Hospital, but was transferred to the Heartland Healthcare Center on 10/27/14 due to the development of a stage 4 pressure ulcer on 9/6/2013. Reason for seeking care. The chief complaint. The patient's chief complaint is multiple sclerosis. History of present illness. The patient claims the MS was onset about 43 years ago when he was 35 years old. He experienced pain on and off for 34 years, but currently is pain-free due to his medications. Aggravating factors include emotional stress, fatigue, and heat. Alleviating factors include exercise through PT, focusing on something other than the pain, and compression leg wraps. Medications like hydrocodone acetaminophen work well to relieve the pain. When experiencing pain, the patient ranked it as a 7 out of 10, 10 being the worst, on the pain scale. The patient claims to have experienced pain throughout his waist and lower extremities before being medicated. The pain experience was described as sometimes being numb, along with feelings of pins and needles, and sometimes a burning sensation. Upon interview, the patient claimed to have a pain level of 1 out of 10. Relieving factors for the pain include laying down to rest and Tylenol. Medications taken for pain include Tylenol, ibuprofen at home, and hydrocodone acetaminophen at the healthcare center. The patient claims that time and working with people at his previous job helped keep his mind off the pain. The MS has impacted the patient's ADLs by way of debilitation. The PT has tremors when contracting muscles and cannot move his legs. His right hip is externally rotated as well, causing a seating deformity. He is unable to carry out ADLs by himself. The pain has caused the patient to become sad, feel hurt that he is not able to take care of himself anymore, and depressed. Comorbidities for the patient include anxiety state, benign prostatic hyperplasia, psychosis, senility, delirium, depression, persistent mental due to CCE, and pressure ulcer on the right hip. Health history. The patient claims to have had no childhood illnesses. The patient claims to have had no chronic or serious illnesses, both physical and psychological, before the MS. There is no family history of chronic or serious illness claimed by the PT. The PT has dementia and is senile, thus affecting his ability to recall immunizations, but claims to be up to date on all. He is allergic to Valium and codeine, as well as red dye. There are no other food allergies, other than the red dye, seasonal allergies, nor otherwise. Allergic reactions. The patient claims to have difficulty breathing and swelling of the lips, face, tongue, and throat when having an allergic reaction. Past hospitalizations. The patient claims to have no past hospitalization other than for the MS. He also claims to have never had any surgeries. Medications. The patient takes 70 milligrams of alendronate once a week every Sunday morning by mouth for bone health. He takes 100 milligrams of amantadine hydrochloride every 12 hours by mouth for Parkinson's. He takes 10 milligrams of dalfampridine ER by mouth every 12 hours for MS. He takes 5 milligrams finasteride by mouth once per day. He takes 5 325 milligram hydrocodone acetaminophen every 6 hours by mouth. He takes 500 milligrams metformin hydrochloride by mouth 2 times per day for his type 2 diabetes. 1 multivitamin per day by mouth for supplement. 20 milligrams of omeprazole capsule 1 before bed every night for GERD. 0.25 milligrams risperidone 1 time per day for PTSD, CNL, psychosis. 40 milligrams of simvastatin by mouth at bedtime for cholesterol. 0.4 milligrams of tamsulosin hydrochloride by mouth at bedtime for benign prostatic hyperplasia. Functional assessment. He used to drink alcohol, but only socially. He currently does not drink. He was a former smoker 18 years ago for 5 years and claimed to have smoked 1 pack a day or less. He currently does not smoke. He eats the food that they give him, according to the patient. For exercise, he attempts minor amounts of physical therapy. He claims to sleep well, about 7 to 8 hours a day, but wakes up sometimes to people screaming. When he was at home, he used to drink 3 to 4 cups of coffee per day, but no longer drinks coffee. He uses no safety devices other than the staff at the center and the Clinitron bed rails. Psychosocial data. In terms of family dynamics, he and his wife met at Ford, where he worked as a systems analyst. She always wore the pants in the family, according to the patient. He's close with his wife, as she visits every other day. He also has 2 sons who call about 5 times a month, but not much more because they don't want to disturb his emotional states. He gets sad when he thinks about not being with his family. With regards to interpersonal relationships, the PT claims to have no friends and does not want any friends at the healthcare center because he doesn't want any more problems to deal with. Perceived pressures include being away from home and family. He has clear positive emotions and attachments to his family and misses them. He had no environmental hazards from his previous jobs other than a possible mental stress from being in the Marine Corps. The patient claims to have gone to Catholic church every Sunday but no longer is religious. His patterns of health care include going to the hospital based on MS flares and the amount of pain he was in. Family history. There is no history of MS or any chronic illnesses within his direct family, claimed by the patient. Vital signs. His heart rate is within the normal range at 71 beats per minute. His respiratory rate is also within the normal range at 19 breaths per minute. And his BP is indicative of stage 1 hypertension with a recording of 143/71. The PT had an oral temperature of 97.8 degrees Fahrenheit upon measurement. Review of systems for the patient's multiple sclerosis, neurological and mental exam. Onset was about 43 years ago. Location is all musculature of his body, upper body, lower body, and periphery. Duration is 43 years. Characteristics include tingling, numb, burning pain. Ranked at a 7 out of 10 during MS flares all over the body. Aggravating factors include emotional stress, fatigue, and heat. Relieving factors include exercise through PT, focusing on something other than the pain, and compression leg wraps. Medications like hydrocodone and acetaminophen work well to relieve the pain as well. Treatment includes the patient for maintaining any musculoskeletal strength, hydrocodone, acetaminophen for the pain, and watching TV in order to keep his mind off his family, thus reducing emotional stress. Impact on ADLs includes debilitation, thus he is unable to live on his own. He also has dysarthria, and thus is unable to communicate effectively at times. Coping. The patient likes to watch TV and keep busy by looking at the learning activities his nurses give to him. The activities keep his mind occupied, allowing him not to think about his family and to reduce any emotional turmoil. Emotional response. He is sad and depressed at times. He is aware of his debilitation and limitations, and it often makes him teary. The patient has numbness, tingling, burning sensations at times, indicative of paresthesia. He has never had a seizure nor lost consciousness suddenly, he claimed. He has concerns about his ability to concentrate such that he actually loses his train of thought at times. The patient claims to have no sleeping issues. The patient is debilitated and is unable to move around by himself. He has tremors in his arms and hands upon muscle contraction. The patient is unable to move his legs and feet. The patient claims that he does not have anxiety and that he is more sad than anything else. He has trouble articulating certain words, indicative of dysarthria. He claims to have no past head injuries. Neurological and mental exam. I performed a mini mental exam on the patient and obtained the following scores. A 6 out of 10 on the level of consciousness section, a 2 out of 3 on the short-term memory section, a 5 out of 5 on the attention span, he spelled world backwards, a 2 out of 3 on the long-term memory section, and a 2 out of 3 on the language section. The patient has MS and was unable to hold any writing instruments, thus I did not have him follow commands with 3 parts, nor did I have him reproduce the image drawn. Overall, I removed 3 of the 30 points due to his disability, making the exam out of 27. The patient received a score of 17 out of 27, which is the equivalent of 18.89 out of 30. This score would put him in the low end of the mild cognitive impairment category. The patient was alert upon examination. Due to the severity of the patient's MS, I was unable to complete the motor function assessment of the neurological systems exam. I was unable to do tests for gross motor balance using the Romberg test, upper extremity fine motor function, nor the lower extremity fine motor function. The patient had light touch sensation in his arms, face, and hands, but lacked sensation in the legs and toes. I did not perform the painful sensation test nor the vibratory sensation test because of the lack of appropriate testing material, pins, and tuning fork. The patient exhibited 1 out of 3 methods of cortical discrimination sensation. He lacked stereogenesis and graphesthesia, but had proprioception. I was unable to test pathological reflexes using the Babinski test, where the normal adult toes should curl and the leg move away from the source of sensation, and I was unable to do the ankylosing test, where there should normally be no tremors due to his leg wraps. Review of systems and physical exam related to stage 4 pressure ulcer. The onset of the pressure ulcer was 9/6/2013. The ulcer is located on the right upper hip. The ulcer has endured from 9/6/2013 to present, about 23 months. The patient has a seating deformity, causing him to constantly place pressure on his right hip, which may account for the longevity of the ulcer. Documentation states that, quote, it is impossible to relieve the right side of pressure due to the seating deformity. Characteristics include 2 centimeters in length by 1.1 centimeters width by 1 centimeter depth. area of 1.728 centimeters squared, with a small amount of non-odoriferous drainage, 76 to 100% pink granulation. The wound texture is normal, the moisture is normal, the color is normal, and there is no infection. Aggravating factors include movement of the right hip, as well as pressure applied to the affected hip. Relieving factors include positioning, such that there is minimal pressure on the wound, as well as acetaminophen. Treatment includes many honey paste and dry gauze used to dress the wound, as well as constant repositioning such that there is minimal pressure applied to the wound. Impact on ADLs includes the patient being unable to reposition himself, but the MS is probably the major contributor. Coping techniques include watching TV to keep preoccupied. Emotionally, the patient is sad and depressed, but this is maybe primarily due to his debilitating MS. Integument exam. Inspection of the scalp reveals mild flaking with no lesions. There's no sign of lumps, bumps, or bruises, nor any deformities. The amount of hair on his head is normal for his age. There is even distribution, and the color is white. The hair is clearly thinning, but is still smooth. Inspection of the skin reveals cleanly, non-odoriferous skin. There is minor scarring on his left lateral forearm, as well as 3 recent 1 centimeter diameter wounds on his right anterior forearm. There is no signs of perspiration. His skin is white and thin enough to see bluish, greenish, tinged vascularity. There are no color changes or pigmentation changes that differs on any specific area of the body from the other. The temperature of his upper limbs and lower limbs is cool to the touch. Upon the pinch test, some of the skin peaked and wrinkled, but relaxed within 4 seconds. There's no sign of edema on the extremities, and mobility and turgor seem normal. The nails on his hands are yellowed, more flat than normal, and have about 0.2 centimeter overhang of the fingertip. The attachment is normal. Capillary refill is normal, with blanching to refill taking 3 seconds. The toenails are thicker, with some toes missing all or part of the nails. The nails are yellow and opaque. The attachment of the nail seems normal, except for the left side pinky toe, and second to last toe missing nails. The right side big toe was missing half its nail as well. Capillary refill at the toe is normal, with blanching to refill taking 3 seconds. Pertinent System Exam 1, Musculoskeletal Exam. According to the NCBI Journal article on MS and limited range of joint motion, it is important to assess the musculoskeletal strength and range of motion because of the positive correlation between MS and the prevalence of joint contracture and muscle weakness. The Neuroscience Research Australia study gathered 156 participants with MS. 56% of partakers had joint contracture in one or more major joints. 43.9% of participants had limited range of motion in the ankle, and 70% of participants had muscle weakness in one or more major muscle groups. The data gathered made evident the prevalence of muscle weakness and limited range of motion of joints, as well as its association with the progression of MS in affected individuals. Clearly, there's a correlation between muscle weakness and limited range of motion in those affected by multiple sclerosis, thus justifying the need to do a musculoskeletal exam, which tests both range of motion and muscle strength to gauge the progress of the disease. The patient has MS, tremors, joint contracture, and muscle weakness, all of which are tested within the musculoskeletal exam. Pertinent System Exam 2, Genitourinary. According to Multiple Sclerosis, Prevalence and Factors Impacting Bladder and Bowel Function in an Australian community cohort, it is important to assess the genitourinary system because MS is linked to urinary incontinence, which negatively impacts emotional health. The study conducted on 73 MS-afflicted individuals resulted in 66% of participants claiming urinary incontinence. Urinary problems had deleterious effects on emotional health in 31% of those affected. The patient has depression, and based off the study, urinary incontinence is a potential contributing factor to his depression by way of negatively impacting emotional health. It is important to do a genitourinary review of systems in order to assess the patient for urinary incontinence and judge if it is a contributing factor to his depression, thus giving caretakers another way to adjust to the patient's needs and positively impact his current emotional status.